Let's move on now to the management of supraventricular tachycardias. The management starts from the education of the patient before the patient comes to the hospital. AV nodal conduction and refractoriness may be modified by vagal maneuvers, and all the patients have to be taught how to perform those. So the patients learn how to do vagal maneuvers, or sometimes they discover it by themselves, and they learn how to bear down as if they're having a bowel movement and hold their breath for 4 or 5 seconds and repeat that 3 or 4 times, or how to do carotid massage at the side of their neck, 4 or 5 seconds of rubbing at the side of their neck, or putting the water in the face in cold water, especially for babies and kids that cannot do the other maneuvers. The sooner someone does the vagal maneuver, the better it is. Otherwise, the adrenaline takes over, and then it's more difficult for the supraventricular tachycardia to stop. For this particular patient, the vagal maneuvers didn't work, so the next thing is to call an ambulance or to go to the emergency room. The first thing that comes to mind for a healthcare professional is an injection of adenosine. Adenosine is a medication that will stop almost 90% of the AVNRT and AVRT cases, and it's effective in almost 50% of atrial tachycardia cases. It goes away very quickly, so although it creates a very unpleasant situation for the patient with hot flash, with burning, with feeling that their heart is pounding, the effect can go away very quickly. The usual starting dose is 6 milligrams IV push, followed by a flash. The closer the IV is to the heart, the more effective that infusion can be. If 6 milligrams doesn't work, then we go to 12 milligrams, which we can repeat, or go to 18 milligrams. And as I said, it creates a very uncomfortable feeling for the patients with dyspnea, chest pain, some sinus pauses, or even some PACs, or even runs of atrial fibrillation, or even ventricular tachycardia for a few seconds, but that usually goes away very soon after. If the tachycardia keeps coming back, even after we have stopped it once with the adenosine, then we need to give something else to last longer, or if we don't have adenosine, intravenous metoprolol, and you can see the doses here, intravenous verapamil, 5 milligrams IV over 2 minutes, intravenous diltiazem. All of these can start their action right away to up to 5 minutes, and hopefully they will keep the tachycardia suppressed for a little longer than what happens with the adenosine. The true problem for the emergency room is when a patient presents for the first time with a wide QRS tachycardia, because one possibility, of course, is for that tachycardia to be antidromic AVRT, which is not necessarily a life-threatening situation, but ventricular tachycardia is high in the diagnostic, in the differential diagnosis for these patients. If we know for sure that the patient has a pathway in previous episodes of antidromic AVRT, then adenosine can be given. However, if we're not sure about the mechanism, different way of action should be taken. Verapamil is contraindicated because it can make an unstable patient even more unstable. Digoxin is contraindicated because it can actually facilitate the conduction, the fast conduction down an accessory pathway. What we try to do is to block the conduction down the pathway if we think that this wide QRS tachycardia is AVRT. In the past, the agent of choice was intravenous prokinomide. Now, these days, the ACLS protocol suggests to go directly to intravenous amiodarone, 150 milligrams IV push over 10 minutes. And of course, if the tachycardia does not stop and the patient continues to be unstable, cardioversion, direct current cardioversion. When we decide how to treat these patients chronically, we can offer them calcium channel blockers or beta blockers, which usually suppress the symptoms, improve them, make them less frequent, shorter duration. If those don't work, we can move to true antiarrhythmic agents. This is rare because an ablation should probably be the next step after this first-line therapy. A few words about pregnancy and SVT. We know that all the arrhythmias increase their frequency during pregnancy. So symptomatic exacerbation of supraventricular tachycardia happens in 20% of the patients with history of SVT. And it's really important to try to avoid drugs as much as we can, but especially for the first 8 weeks of pregnancy. During the second and the third trimester, we have to think of the effect of the medications on the fetus in terms of its growth and development, as well as proarrhythmia for the fetus and the mother. This is the table of the possible agents and maneuvers during pregnancy. So during an acute episode of SVT, vagal maneuvers, class 1 indication, adenosine, it is safe and it works. Cardioversion, if the mother is very unstable, and then intravenous metoprolol, propranolol, verapamil, first line of action. For chronic prophylactic therapy, digoxin had been used for many, many years. We are moving really away from this agent because of its low efficacy, but it is still safe for pregnant women. Metoprolol is also safe. Propranolol has been tested for a long time. If we need to move to antiarrhythmics, sotalol, flecainide, procainamide are acceptable. Quinidine, we don't use that much anymore. Propafenone, verapamil. Catheter ablation, the patient has to be exposed to radiation, and that means that the fetus will also be exposed, so we try to avoid it as much as we can. Atenolol and amiodarone are really contraindicated during pregnancy. Beta blockers can cause some side effects for the mom and for the child. Quinidine, we don't use it that much anymore, and amiodarone only if there are life-threatening arrhythmias that have to be treated. The cornerstone of management of supraventricular tachycardias is the catheter ablation procedure. And as we discussed, it is the attractive alternative for patients who either desire to avoid medications or are unresponsive or intolerant to medications. Also, in patients with WPW that are at high risk, people who have history of atrial fibrillation, who conduct very fast, who had syncope during palpitations and have WPW. Also, women in childbearing potential that have a lot of episodes during their pregnancy. Young patients, a child who's 15 years old is going to have to spend 80 years taking medications to suppress an SVT that can be easily treated with a procedure that will take 20 minutes to a couple of hours. High-risk occupation patients, patients with coronary artery disease that cannot tolerate tachycardia, and sometimes truly patient and physician preference. Should asymptomatic patients with WPW be considered for an EP study and ablation? We talked a little bit about the algorithm for asymptomatic children. Similarly, in asymptomatic adults, Paponi and colleagues took them to the lab a few years back and collected the results of the patients who half of them underwent an ablation, even if they never had an episode before, but they had inducible SVT during the procedure, and half of them who actually were not offered the ablation. They were just studied, and then the catheters were pulled out, and they were followed clinically. Up to 5 years of follow-up, the patients who had an ablation did remarkably well. The patients who did not have an ablation had to come back for an ablation or developed symptoms that needed management, and actually one patient here had sudden cardiac arrest. So the authors made the point that maybe this patient should be undergoing an ablation. AV and RT ablation, just to give you a little bit of an outline what we do in the lab, we put catheters specifically targeting the triangle of Koch, this area between the His bundle, the coronary sinus os, and the tricuspid annulus, where we think that the slow AV nodal pathway lies, and we perform ablation, which means radiofrequency burning or cryoablation, freezing the area of the slow pathway, modifying it without affecting the AV node or the fast pathway. And this has found to be remarkably effective to control the symptoms of AV NRT. For patients with pathways, AVRT, we take them to the lab. This is a patient with a pathway at baseline. You can see the delta wave and the short PR. And we induce the tachycardia, and you don't need to necessarily understand that, but the way we know where the pathway is from the activation sequence during the baseline EP study and during the tachycardia. We can tell, for example, here that the earliest activation is at the coronary sinus 5-6, so that means a left-sided pathway, a left posterior pathway, and then we direct our catheter where that earlier signal was, and we can change the activation sequence, ablating the pathway. So here's the example again. Our catheters, here's a catheter recording the His node. Here is a catheter up in the high right atrium. We usually have one in the right ventricle as well. And we take the ablation catheter and we burn where we identify the location of the pathway. Atrial tachycardia, similarly, we address the earliest site where the origination of the signals are. We have this very helpful system, mapping system. It is called electroanatomic mapping or cartomapping, that helps us identify by color signaling the earliest activation by the color red here. And once we identify it, we can go and put our radio frequency ablation spots there, and this way control the tachycardia. For typical flutter, you remember we said it's a reentry around the tricuspid annulus. We go and we create, as we call it, a line of block between the tricuspid annulus and the isthmus, the origin of the connection with the inferior vena cava. So essentially, we drop a line by spot ablation that interrupts this re-entry around the tricuspid annulus. Complications associated with an ablation procedure, I usually tell my patients less than 1% for anything serious to happen. Complete AV block by affecting the normal atrioventricular conduction, less than 1%. If it happens, of course, to a young patient, is really an unfortunate event for which someone may need a pacemaker. Much less than 1%. Valvular damage, thrombotic events, pulmonary embolism, stroke, peripheral thrombotic or embolic events, exposure to radiation, vascular complications, AV fistula, hematoma, tear, pneumothorax, long-term arrhythmia. Sometimes by the ablation, you may make a tachycardia even easier to be induced. Very uncommon, as well as some coronary complications and death. Really almost unheard of. So a very safe procedure in general. Success rate for AV and RT over 96% with a small recurrence rate. AVRT over 95% with a small recurrence rate, atrial tachycardia similarly, and atrial flutter similarly. 2 words on the sources of energy that we use for ablation. One is burning, radiofrequency energy, and one is freezing, cryothermal ablation. Why to have 2 different sources? Because cryoablation sometimes can be safer, especially when we have to ablate very close to the AV node. With radiofrequency, the lesion is uniform and almost immediately as deep as the end of the procedure. The beginning of the procedure and the end of the procedure is essentially as deep, almost right away. So you can create a deep lesion almost immediately after you come on ablation. With cryoablation, the freezing of the tissues is gradual. So if you have initially frozen up to here and you see that you're creating AV block, you can always stop, and that can create a reversible problem at the area. So when we feel that we are very close to the AV node, cryoablation may be a preferred mode of ablation, and we can see here how the SVT was going on. The cryoablation started here, and as it was getting colder and colder, the tachycardia stopped and had a final successful event. At this point, I would like to stop. Thank you very much for your attention.